So welcome. In today's session, we are going to look at diabetes, and at the end of this session, you should know how diabetes mellitus type 2 comes about, and it is brought about by insulin resistance combined with the dysfunction of beta cells. We are going to look at metabolic changes associated with the type 2 diabetes mellitus and what are some treatment options available for type 2 diabetes mellitus. Welcome all, my name is Wallace Munyin and I'm the doctor. Type 2 diabetes mellitus. Now, it is the most common form of disease afflicting more than 90% of the US population with diabetes. So, if you have diabetes, if you take a population with diabetes, more than 90% will have diabetes. Okay, so diabetes type 2, that is. So, less than 10% will have diabetes type 1. Okay, so you can see how serious it is. It usually develops gradually without symptoms. Okay, then the disease is often detected by routine screening tests. Okay, however, many individuals with type 2 diabetes have symptoms of polyuria. They usually have polyuria and polydipsia, that is frequent urination and increased thirst of several weeks duration. Polyphagia may be present, but it is less common, so the appetite remains the same. Now, patients with type 2 have a combination of insulin resistance, they have insulin resistance and dysfunction of beta cells, but do not require insulin to sustain life. That is why it can also be called non-insulin dependent diabetes mellitus. However, please note this, in more than 90% of these patients with type 2 diabetes, insulin therapy eventually will be required to control hyperglycemia and keep the HbA1c, that is glycated hemoglobin, its concentration to below 7%. Okay, the metabolic alterations observed in type 2 are milder than those observed in type 1. Okay, because why? Insulin secretion in type 2, although inadequate, or although the cells are resistant to insulin, it will restrain ketogenesis in the liver, and this will prevent the development of diabetic ketoacidosis. So patients with type 2 diabetes mellitus do not develop diabetic ketoacidosis, and if they do, it is very rare. Okay, diagnosis is based on the presence of hyperglycemia. Okay, and pathogenesis. The pathogenesis of type 2 diabetes mellitus does not involve a virus or an autoimmune antibodies as seen in type 1. Okay, and it is not completely understood. Okay, now an acute complication of type 2 diabetes, especially in the elderly, is associated with hyperosmolar hyperglycemic state, which is usually characterized by severe hyperglycemia, dehydration, and altered mental status. Okay, so is type 2 diabetes the same as non-insulin dependent diabetes mellitus? Is it? Some would say yes, others no, others both. Now let's see. Type 2 diabetes is characterized by hyperglycemia, insulin resistance, impaired insulin secretion, and ultimately beta cell failure. So at first, it will be non-insulin dependent, but as the disease progresses and worsens, and you have a deterioration of the beta cell, eventually there will be need for insulin therapy. And this is why some scientists have eliminated the designation of type 2 diabetes mellitus as non-insulin dependent diabetes, because eventually, as the disease worsens and the beta cells deteriorate and become dysfunctional, there will be need for insulin therapy. So in the latter stages, it will be insulin dependent. Insulin resistance refers to the decreased ability of the target cells, such as the liver, the adipose, and the skeletal muscles, to respond properly to normal or elevated circulating concentration of insulin. Now, for example, insulin resistance is usually characterized by there will be increased hepatic glucose production. Okay, so you have increased glucose production but decreased glucose uptake. by the muscles and the adipose tissue. Remember, glucose uptake in the muscles and the adipose tissue is insulin sensitive because we have the GLUT4 transporters. Okay, I've done a video on that. Maybe you should look on how there is that cascade that goes, and also leads to increased adipose lipolysis with the production of free fatty acids. So the levels of free fatty acids in the blood will be increased. Now, insulin resistance, how is insulin resistance and obesity related? Although obesity is the most common cause of insulin resistance and increases the risk of type 2 diabetes, most people with obesity and insulin resistance, they do not develop diabetes. How? In absence, as long as you have absence, let me even, in fact, take a pen. Now, in absence in defect in beta cell function, an obese individual can compensate for insulin resistance. How will they compensate? There will be elevated levels of insulin. That is how they compensate for the insulin resistance. I have a diagram in the next page to show you how this occurs. And in that diagram, you'll see that insulin secretion in obese patients is up to 3 times higher than in lean individuals. This higher insulin concentration usually compensate for the diminished effect of the hormone as a result of the insulin resistance. And that high insulin will produce glucose levels similar to those of normal individuals. Okay, let me show you that right away. Here we are. You can see these are the insulin levels. Then after meal, you can see that the insulin concentration in this is the normal individual in blue. You can see they rise, but up to that level. But in obese, you can see where they reach up to 3 times higher insulin levels. Okay, because they are resistant. Okay, but what about their blood glucose level? You can see in red and in blue, you can see almost the graph is similar. Okay, so the blood glucose is kept within the same narrow range throughout the day in both normal weight and obese individuals. So these obese individuals here can be considered normal. Yes, they have insulin resistance, but their beta cells are not dysfunctional, and they compensate for that insulin resistance by producing more and more insulin. Insulin resistance and type 2. Now, how does insulin resistance bring about type 2 diabetes? Now, insulin resistance alone will not lead to type 2, but rather, type 2 usually develop in insulin-resistant individuals who also show impaired beta cell function. So, beta cell function is impaired. Now, insulin resistance and subsequent risk for development of type 2 is commonly observed in individuals who are one, obese, okay, obese, physically inactive, and the elderly. And also, 3 to 5% of pregnant women usually develop gestational diabetes. Okay, now these patients are unable to, they are usually unable to sufficiently compensate for the insulin resistance with the decreased insulin release. So even if you have insulin resistance, but you can compensate for it by producing increased insulin, we will not consider you diabetic. But if you have impaired beta cell function and have a decreased insulin release, you will definitely develop type 2. Now, I have a figure which will show you how that comes about. Okay. So, here you can see that. Okay. Here you can see, let's take, this was the year when the diabetes was diagnosed. This is an obese patient, individual. Now, at first, you can see here, the blood sugar levels were normal. They were normal here. They were normal. Why? And if they are normal here, you can see that the beta cells here, they were not impaired. In fact, they were compensating for the insulin resistance by producing increased amount of insulin, condition known as hyperinsulinemia. Hyperinsulinemia. Okay. Then, when the patient, now when the beta cells, at this point, when the beta cells became impaired, they started to become dysfunctional, you can see insulin started to fall. And when insulin levels fall, their fasting blood glucose increased. Now that is when type 2 diabetes mellitus came in. There is hyperglycemia, increased blood glucose levels. Okay. And you can see subsequent B cell dysfunction occurs, marked by declining insulin secretion and worsening hyperglycemia. Okay. Now, what are the causes of this insulin resistance? Insulin resistance occurs with weight gain and decreases with weight loss. So the more the more you gain weight, and the more your cells become resistant to insulin. How? And especially adipose tissue, particularly in the abdomen, is key in development of insulin resistance. So those people who have increased adipose in the abdomen region, those ones are at a higher risk of developing insulin resistance. Now, adipose is not only an energy storage tissue, but also a secretory tissue. Okay. Now, with obesity, there are changes in adipose secretion that result in insulin resistance. Now, these include the secretion of pro-inflammatory cytokines such as interleukin 6 and the tumor necrosis factor alpha by the activated macrophages. Now, these cytokines lead to inflammation, and inflammation has been associated with insulin resistance. Increased synthesis, also the adipocytes secrete more leptin, and the leptin has pro-inflammatory effects. Also, they decrease the secretion of adiponectin, the adipocytes, and adiponectin has anti-inflammatory effect. Now, what is the net result? The net result is that you will have a chronic low-grade inflammation. Okay. Now, one effect of insulin resistance is increased lipolysis, and the lipolysis is accompanied by production of free fatty acids. Now, free fatty acids availability decreases the use of glucose, which will lead to increased blood glucose levels, hyperglycemia. Now, it also increases the ectopic deposition of triacylglycerols in the liver, leading to hepatic steatosis. Now, steatosis results in a disease known as non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease. And if the non-alcoholic liver disease is accompanied by inflammation of the hepatocytes, a more serious condition might develop, which is known as the non-alcoholic steatohepatitis. Okay. Also, the free fatty acids they have a pro-inflammatory effect, and the long-term effect is that the free fatty acids usually impair insulin signaling. Okay. So we are that we have obesity. Okay. Then let me take the eraser faster, which will lead to change in adipose secretion, leading to insulin resistance. Insulin resistance leads to adipose lipolysis and decreased fatty acid oxidation. Remember, even adiponectin increases fatty acid oxidation, but since its secretion is decreased, there will be decreased also fatty acid oxidation, leading to increased free fatty acids. Also, in the liver, there will be increased hepatic glucose production by gluconeogenesis. Also, remember the muscles and the adipose tissue, they require the GLUT4 transporter, which is insulin sensitive to take up the glucose, but since they are resistant to insulin, there will be decreased glucose uptake, and this will lead to increased blood glucose levels, hyperglycemia. Now, dysfunctional beta cells. Now, in type 2 diabetes, the pancreas initially retains beta cell capacity. Okay. Now, but however, with time, the beta cells become increasingly dysfunctional and fail to secrete enough insulin to correct the prevailing hyperglycemia. Now, for example, insulin levels are high in typical obese type 2 patients, but not as high as in similarly obese who do not have diabetes. Okay. Now, if you take an obese person, one who is normal, non-diabetic, and another one who is diabetic, in the one who is non-diabetic, or in there'll be very high insulin levels because they are, the beta cells are compensating for the insulin resistance. But in the diabetic one, the beta cells have become dysfunctional, so insulin levels will be lower. Now, thus, the natural progression of the disease results in declining ability to control hyperglycemia with endogenous secretion of insulin. Now, deterioration of beta cell function may be accelerated by toxic effects by the sustained hyperglycemia, elevated free fatty acids, and pro-inflammatory environments. These factors lead to the deterioration of the beta cell. Here we are, can see insulin resistance may be due to obesity or genetics or sedentary lifestyle or aging, but the beta cells compensate and produce increased insulin, hyperinsulinemia, but with time there is impaired glucose tolerance and leading to hyperglycemia, causing a decline in the beta cell function, which can be also accelerated by genetics, glucose toxicity, also free fatty acid toxicity, also the pro-inflammatory factors. The environment is inflammatory, leading to deterioration of the beta cell, which now eventually leads to type 2 diabetes. These are the complications, the long-term complications associated with type 2, such as microvascular complications and macrovascular complications. Microvascular, we have retinopathy, that is which leads to blindness, neuropathy, mental illnesses, nephropathy, kidney failure. Macrovascular, such as cardiovascular diseases and stroke. Now, what are the metabolic changes? Hyperglycemia is caused by increased hepatic production of glucose by gluconeogenesis, and yes, there is increased hepatic production of glucose with decreased glucose uptake by the muscles and adipose. So the net effect is that the blood glucose level will be increased. Okay, ketonemia is usually minimal or absent in patients with type 2. Why? Because the presence of insulin. Yes, remember these patients, they have insulin, but they are resistant. It is the cells which are resistant to this insulin. But even in presence of insulin resistance, that insulin is able to restrain hepatic ketogenesis. So there will be no production of the ketone body. So it is the type 2. In type 2 diabetic patients, rarely will they get diabetic ketoacidosis. But in type 1, because insulin, there is no insulin, that is what causes the diabetic ketoacidosis. Then you have dyslipidemia. Now in liver, free fatty acids are converted to triacylglycerols, which are packaged and secreted in form of very low density lipoproteins. Now, dietary TAG-rich chylomicrons are usually synthesized and secreted by the intestinal mucosa cells following a fatty meal. Now, because lipoprotein TAG degradation catalyzed by lipoprotein lipase, lipoprotein lipase is found in the adipose tissues, and it requires insulin to be activated, but these cells are insulin resistant, so it is somewhat inactivated, so it cannot cleave the very low density lipoproteins and the chylomicrons to convert them into the the triacylglycerols to take them up, so it cannot be able, so the adipocytes cannot be able to take up very low density lipoproteins and the chylomicrons because the lipoprotein lipase its function is impaired. Okay, and that will lead to increased chylomicron and very low density level, very low density lipoproteins levels. So the plasma levels of chylomicrons and VLDL will be elevated, resulting to hypertriacylglycerolemia. Okay, hypertriacylglycerolemia. Now, okay, that is that. Here we are, you can see amyl glucose is taken, but it cannot be absorbed by, it cannot be taken up by the adipocyte, because here the GLUT4 transporter here these cells are absent, are resistant to insulin. Hence, the GLUT4 is not there to take up the glucose. Also, there is increased hepatic glucose production. You can see glucose production, gluconeogenesis. So this will lead to elevated blood glucose levels. Okay. Also, after fatty meal, THGs are transported in form of chylomicrons, and these chylomicrons cannot also be taken up by the adipocytes, because the lipoprotein lipase here, lipoprotein lipase required to take to cleave these lipoproteins cannot. It is sensitive to insulin. Its function is impaired because these cells are insensitive to insulin. They are insulin resistant. Also, you can see, but there is increased lipolysis. You can see increased lipolysis, and these free fatty acids will go to the liver to form triacylglycerols, which can be stored in the liver, leading to hepatic steatosis, which can cause the non-alcoholic fatty liver disease, and if followed by inflammation, can cause the non-alcoholic steatohepatitis. But this also triacylglycerol can be packed in form very low density lipoproteins, which cannot be taken up by the adipocytes, because due to absence of the lipoprotein lipase, hence they accumulate in the plasma, causing hypertriacylglycerolemia. Okay, that is that. Don't think. Now, what are the treatment options? Now, what is the goal of treating type 2? It is to maintain the blood glucose concentration within the normal range and prevent the long-term, the development of long-term complications such as the microvascular and the macrovascular complications. Now, weight reduction, exercises, medical nutrition therapy such as dietary modifications, they usually correct hyperglycemia in newly diagnosed type 2 diabetes mellitus patients. Okay, so just reducing weight, that is enough, because remember, insulin sensitivity increases with weight reduction. Now, you also have oral hypoglycemic agents, or also known as oral anti-hyperglycemic agents, or drugs, such as we have category of drugs known as biguanides with the metformin. Metformin is an example of a biguanide, and it usually decreases blood glucose levels by inhibiting hepatic gluconeogenesis, and also promotes glycolysis, the usage of glucose. Its adverse effect is that it can cause lactic acidosis. We also have another category of drugs known as sulfonylureas and magnetides. These ones, they fall under a category of drugs known as insulin secretagogues, and they usually inhibit the potassium channels in the beta cells, leading to membrane depolarization, which causes the opening of the voltage-gated calcium channels in the beta cells, causing calcium influx and insulin secretion. Then you also have another class of drugs known as thiazolidine diones, which usually bind thiazolidine diones. They usually bind to the peroxisome proliferator activated receptor gamma, which is a nuclear factor, and leads to leading to increased peripheral insulin sensitivity. So the adipose and the muscles can take up glucose, reducing the blood glucose level. Then we also have other drugs known as alpha glucosidase inhibitors, an example being acarbose, which usually decrease absorption of dietary carbohydrates by inhibiting the alpha glucosidase found in the enterocytes. Okay, but their adverse effects is that they can lead to flatulence and bloating. We also have other drugs which usually inhibit the sodium glucose cotransporter 2 found in the renal tubules. Okay, and the work of this sodium glucose cotransporter 2 is to transport glucose from the ultrafiltrate back into the body. So by inhibiting this cotransporter, we increase secretion, glucose loss into the urine. So more glucose is secreted via the urine, leading to which can lower the blood glucose levels. And okay, these drugs are also known as glycosurics. You can find these drugs also known as glycosurics because they promote glycosuria. Then we have incretin therapy. Now, incretins are peptide analogs which usually stimulate the pancreatic beta cells to release insulin, and they usually include the glucagon like peptide 1 produced by the L cells, and we also have another one known as GIP, the gastric inhibitory peptide, or the can also find some other text calling this the glucose dependent insulinotropic polypeptide, which is produced by the K cells of the gastric mucosa. Now, these ones they usually they are agonists. They look like those uh, those they look like these incretins, and by they are similar, they are analogs to them, so they will promote the beta cells to produce insulin. Also, these incretins are usually degraded by an enzyme known as the peptidase 4, and once we inhibit that enzyme, we can increase the levels of these incretins. Okay, so an example of a DPP4 inhibitors can include sitagliptin. Okay, so those are some of the treatment options available. You can also use amylin analogs, but that maybe we look when we discuss pharmacology. And I think we have come to the end of that session. It was a good session, and I hope you have understood to diabetes mellitus. So thank you for your attention, guys. Please subscribe for more anatomy and biochemistry content. Thank you.